So, good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. So, thank you. Before we get going, I want to say thank you to all of you for tuning into the show. It means a lot to me. I know that you're busy people. You have kids, you have grandkids, and you're trying to get them here and there and everywhere. And I know that that is a lot of work, but the fact that you tune in means a lot to me. So thank you for doing that. If you like what you hear and you're motivated, please share it with friends and family. We are building a listener base, and not for me, but for the people I bring on the show. All of the people I bring on are remarkable people who are doing things. They're out in the community, and today is no exception. It's an incredible honor for me to welcome to the Hamilton Review, Dr. Susan Partovi. Dr. Partovi, welcome to the Hamilton
Hi,
Review.
thank you so much. I'm
So,
excited.
Dr. Partovi, I'm going to introduce you. She was born and raised in Los Angeles. She is the medical director of the Homeless Healthcare of Los Angeles, an internationally recognized expert in the field of street medicine. She's also the co-founder of an organization called HEAL, HEAL, which is a nonprofit organization that brings medical students and others with her to Haiti. We're going to talk about HEAL, Susan, before this conversation is over. But so I'm so thankful that you're on my show. I appreciate that so much.
Sure.
Um, Dr. Partovi, before we kind of get into your book, by the way, she's also an author. She's written a book called Renegade MD. You'll understand the name Renegade in a minute here, friends. But before we get to the Renegade or anything like that, I'm curious. We like to hear about who you are, your background, where you were you're raised in LA, but tell us a little about who you are. And so I'm going to turn the microphone over to you and go for it.
Thanks. So, yeah, grew up in LA. My father came in the 60s. He was from Iran, and he was from a Persian Jewish family. And my mother was raised in upstate New York, Russian Jewish family. And they met in Los Angeles. Um, and I grew up, I since 7 years to 17, grew up in Brentwood, which is a nice suburb of Los Angeles. And I was the only child of that couple. I do have my mom had a son and a daughter before me, so I had half siblings, but pretty much grew up as an only child. And so I had a lot of time to think. And I had a great group of friends. We called ourselves the Dorothy Street Gang, grew up on Dorothy Street in Brentwood, and just was constantly looking for more. I didn't get the family wasn't very lovey-dovey, mushy-gushy. Um, and I think I missed out on that. And so I was looking for stuff, right? And constantly looking for, is this the right fit? Is this the right fit? Um, and I did become a Christian when I was in high school, and really started, going to church at Brentwood Presbyterian Church. And one of the things they did with their high schoolers is they brought them to Tijuana for Easter break to build houses, which at the time I think was this was in the 80s, so it was kind of a common thing to do. But that was really my first look at just abject poverty. So it was a real eye opener for me. And it was a time where I was, when you're at that age, trying to figure out what you want to do. And I knew I wanted to be a doctor. Um, but I was like, okay, this is this is the population I want to be working with. And I really dove in and started started volunteering with a physician assistant in the same area in Tijuana on
Right.
Saturdays. And so I learned, doctoring. I learned, how to speak Spanish, but at the same time, I really caught like he was very funny, he was very down to earth, and I really just got that sense of like needing to be with your patients and the parents and it wasn't a hierarchical relationship. It was a companion type relationship. So I really
Yeah.
learned that from him and
So
learned.
I know that you started to go down to Tijuana. I mean, I think on a weekly basis almost. So you were going down there all the time, and from my understanding of your book, you were actually you got to know these people. You got to know who
Yeah,
they were,
yeah,
and they became people that were not just whoever walked in the clinic, but these were people that you knew.
yeah, yeah,
And this mentor of yours was a superstar at really inclusiveness
yeah.
and loving on these people.
Exactly, and exactly. And he brought humor, which I try to bring as well. I mean, it's just part of my natural personality. So I try to be as normal, for lack of a better word, as possible when I'm with patients. So yeah,
Humor is I think when you engage people in humor, by definition, you're kind of coming down to their level, and you're enjoying. Listen, first of all, when you're and I try to engage humor as well in my office, you have more fun. You're
yeah,
having a little bit of fun.
yeah,
If it's all, cut and dried, no humor, it's not as much fun. So I hate to say it, but I think I'm a pediatrician because I'm still a kid inside,
right.
and I enjoy laughing. I enjoy having fun. So humor is a good thing. Good for you. So you went to Tijuana, you saw abject poverty. You begin to realize that there was a big barrier between our country and Mexico in terms you cross the border, and suddenly you're in a different world.
Completely,
And how did that affect
completely.
you, Susan?
How did it affect me?
Yeah, how did it affect you?
Well, that's when you start realizing you know, there's this like unfairness. Like why did they have to live that way and I get to live a certain way, And so I start seeing the disparities and I start seeing the injustice and so I guess that was what was driving me to whether it's on a personal level or a big swath level is try to level the playing ground a little bit of injustices. So I mean I wasn't consciously doing it, mind you,
Yeah,
but I think that was a big motivator for me. And also, and this is, to this day, like when I meet someone who's completely, disheveled and nails out to here and dreads down to there, like I can still find something to relate to them about, right? I still try to see them, as me or, as relatable. And so I think that's what I was doing in those formative years.
yeah, it's pretty clear from your book that you kind of went into the medical profession, and I don't mean to necessarily flatter you, but I think you went in for all the right reasons because you were able to take your knowledge, your scientific knowledge, and put it to work. But you also never ever, and it's very clear to me from your first chapter. I want to talk about your first chapter in your book. By the way, friends, the name of the book is called Renegade MD. Renegade, Renegade, like just exactly the word renegade. MD is M period D period by Susan Partovi, and you can find it on Amazon. I did, and it's actually an amazing read. But
Thank
one
you.
of the things I mean, this development of your sense of purpose and the sense of humanity uh, was very evident, certainly when you were doing your OBGYN rotation. You talk about this in your first chapter of your book
Yeah.
about this dear woman from Guatemala who
Yeah.
had cervical cancer. I think this is worthy to actually kind of give us a backdrop on kind of who you are and how you dealt with that situation. So you were down at Harvard General, if I'm not mistaken,
Yeah.
and
Yeah.
you and your chief resident at that point had a little bit of disagreement in terms of how you would deal with this lady. Can you tell that story?
So this is actually a really difficult story for me, and it really haunts me because there was something that was happening that I wasn't I didn't have a good leadership around this very difficult um, event in one's life. And basically, she was dying. And there, now as an adult in medicine, like I know how it's supposed to go. I mean, it's not supposed to go, but as far as communication, as far as communicating with the patient, communicating with the family, letting them be the driver in the seat. And so, and I don't know if it was because she didn't speak English, or she was poor, or she was from Guatemala, or is this how the gyne team, does end of life? Like I still don't know. I hope not. But you know, they were talking about how to best take care of her, but they weren't including her or the family in that decision making process. So she had such severe cancer that it was blocking her ureters, which brings the urine from the kidneys. And if that happens, then you go into kidney failure and you die. And so the question, sometimes is, do we stent those ureters to allow the urine to pass from the kidneys to the bladder and give her more time to live, basically?
Yeah, right,
And
exactly.
they had made the decision for her and said, we're not going to stent. They didn't even ask the patient what she wanted. And they just made this decision on their own. They're like, well, kidney failure is not a bad way to die, so we'll just do that. And I'm, again, like in my neonatal stages of being a doctor, like I'm like, okay, I'm not exactly sure what you're supposed to be doing, but this doesn't feel right. Like
Yeah.
I couldn't put my finger on it. And then even when and even when there was a point when she was suffering because she couldn't breathe very well, and I knew the physiology, and I knew why she couldn't breathe very well, and they weren't taking it seriously enough, and her poor family had to watch her suffer. And I'm there trying to say, what else could we be doing? Like, I didn't know that, oh, you give morphine, end of life, so that that they're not suffering, and it all helps bring the fluid away from the lungs. Like, I didn't know that as an intern. They should have known that. They should have taken the time to figure that out. And so there is, I talk about it. There is a point in the book, and in my brain, that's kind of solidified, where I see her struggling for air.
Yeah.
And it haunts me that we just walked right by her room, not because I didn't know what else to do, and my chief resident and my attending didn't take the time to do anything. And maybe I should have gone to somebody else. I could have gone to my own chief residence of family medicine, and but at the time, you're tired. You're upset, and you're trusting that your higher ups know what they're supposed to be doing. And so it was really
So I read that story, and I think there was a certain callousness. It was like she's gone. I mean, there and definitely this was a very stage 4 disseminated carcinoma that was going to take her life sooner or later. Um, I do what bothered me most about that story when I read it, Susan, was the fact that there was this lack of humanity, and you talk about that the importance of caring for people, just dealing with people as human beings.
Right.
And there's this tendency, and I can tell, I know I can almost visualize in my mind
Right.
what was going on because I've seen it because
Yeah.
when I did my training,
Yeah.
there's almost this the load can be so intense and great, and you're trying to you're just kind of trying to live through each day
Yeah.
that you sometimes just kind of write people off. You kind of go, they're gone, they're gonna die. We
Yeah.
know that they're gonna die. We've seen this before, and don't waste your time, don't waste
Right.
resources, don't waste your care and compassion on that person. And it is such a you actually talk about treating patients with compassion, with concern, and conscientiousness is how you put it.
Mhm.
And I love that, and I think that that is really a clarion call to all healthcare people,
Right.
doctors definitely, nurses as well, because nurses do
Yeah.
it too. You know
Yeah.
that, Dr. Partovi, that nurses can be equally cold-hearted. But I think if we're in this profession where I do think this is a little bit of a calling to treat people as human beings. Um, anyway, so I do, and that I think that that sparked something in your mind, and also demonstrates to me who you are as an individual, that has kind of followed your course through time. Um, you talk also about you talk about a guy named Pedro, and you also kind of link in your father because your father sadly died
Mhm.
of cancer as well, and you linked this with Pedro. Can you tell us a little bit about that kind of linkage because this is important too?
Yeah, I had this is great. Um, so my father died. I was a third year. I was third year chief of residency, and so he died in May of my third year. And we then started a fourth year chief year. So I was also a fourth year chief. And so I was on as, I still was at Harbor as chief, and a couple months later started taking care of Pedro. And the interesting thing, and this is something that's very common that we see a lot, where the wife says, um, don't tell him he has cancer because he's going to lose his will to live. Like, I can't tell you how
Yeah.
many times I've heard that, and you probably have heard that as well. It's very common in the Latino culture. Might be, the Persian culture doesn't do well with death either, as far as, you
Well,
know, some,
the Norwegian Swedish culture doesn't do too great with death either, so just kind of throw that in there.
okay.
Right.
So, so I shouldn't label it bad or good. It's just different. It's just different. And so it was hard because here I have a patient in front of me, and I was taught to not be paternalistic, to discuss everything with the patient. And then I have my mentor, or one of my attendings, um, and I'm talking to him about it, like I need help. And he is, and to this day, he still is a doctor at Harbor in family medicine, and he's really well known for having amazing relationships with his patients, Dr. Castro. And so I was asking him, like, what do I do with this? And then he starts getting very philosophical. He's like, well, what does their culture say about death? What is the meaning of death? What is their meaning of death? And so I'm like sobbing because I just, had to go through all this with my own family. And I'm like, I don't know what the meaning of death is. I don't, it was like a mess. And, and so he comes into the patient's room with me, and Dr. Castro speaks Spanish, and this is Spanish speaking gentleman. And he says, how do you want us to, take care of you? If you had life threatening, ending, illness, he even used the word cancer. If you had cancer, would you want to know? And he's like, no. Like he didn't even like, there's no hesitance to,
Yeah.
and it was like, oh, so you ask the patient what they want. I was like, and it was very, it was like, a light, opening up out of the sky kind of a thing. And that's, we didn't tell him to, his dying till his death, basically. And there was a point where the two of us were by ourselves, and he was having shortness of breath, and because his lungs filled up with fluid, and it was very Hollywood feel, because we were at a part at Harbor that they only had 3 beds in the higher level of care, like the highest level of care in the emergency room, and it's changed now. And then you could see the X-ray right behind him, and it was just the two of us. And he's just like, what's going on? What's happening? Why can't I breathe? And I'm just caressing him. And I'm like, it's okay. You have fluid in your lungs. We're going to take the fluid out. And I just knew not to tell him that, oh, it's cancer causing fluid in your lungs. So,
Yeah.
and I wanted to go back to what you were saying about the woman with end stage cancer. It's not that we have to treat humans with kindness and caring and grace and conscientiousness and lack of judgment, but especially people who we normally don't see as maybe our equal. So had been a rich woman from Brentwood at UCLA, guaranteed it would not have gone down like that. So there's something to be said about not only bringing humanity to people, but making sure that those who society tends to look down upon, that we're lifting them up to our level, and to the
Sure.
highest quality of care. And so I think that was an important part of taking care of the woman from Guatemala. Yeah.
No, amen to that. And I can tell that just the short interaction we're having here, I can tell that you really are a person that looks people in the eye. You take time with people. A lot of people lose that. Some people have that going into medicine.
Mhm.
The grind, the push, and everything else. It's hard to maintain that, and it's really something that you're inspiring me even right now, Susan, with this conversation. I want to jump ahead because what you're doing now is remarkable. You kind of begin this work on the street, and you are referred to as a street physician. You are how does it is I'm reading from your book, a doctor's story from the streets.
Yeah,
So you have been out there in Los Angeles for quite a while now,
yeah,
taking care of really the people who are referred to as the people experiencing homelessness
right.
out there, and there are lots of them here in Los Angeles.
Yep.
Um, Tell us a little bit about how you ended up into that world, because this is fascinating to me. You might also want to throw in a comment about your sister, because I think that was a big issue in terms of how your advocacy for people
Mm,
who don't have advocacy
mm.
was spawned to a degree by that experience. But can you tell us a little bit about how that evolution, because not too many people go into homeless healthcare.
Yeah. Um, So I actually stayed on at Harbor UCLA. I was an attending on faculty there for 6 years. And I did get a little, uh, what's the word when you jaded by the politics?
Weary is the word.
Yeah. It, but then to find out that there's politics wherever you go. Don't
True.
leave because of politics. Um, one of my best friends was working at the Venice Family Clinic, and she's like, come work here. And so it was different to go from academia to community medicine. And they were, one of the first agencies to be taking care of people living in the streets. At the time, the way they were doing it was going to shelters, and they had a program specifically to bring medical care to people experiencing homelessness. And just was like, oh, I'm all over that. Like I mean, it was just easy. I was like, yeah, I want to do that. And so I started doing that and started getting involved in the National Healthcare for the Homeless. They have annual conferences. So I started going to those. And so it's good because you start meeting other people who are doing the same thing you're doing. And I met a couple people who I consider kind of mentor-esque, Jim Withers and Jim O'Connell. Both are internist physicians. And Jim O'Connell is probably, there's actually a book written about him called Rough Sleepers by, who is it? Oh, Tracy Kidder. And he's probably like the father of street medicine, where he started seeing patients in the streets.
Yeah.
Really, really great guy, kind of Jesus-esque. the
Yeah.
way,
Yeah.
the way he talks, the way he walks, he's very humble. And Jim Withers, who's a little, slightly younger than the other Jim, decided that he wanted to bring street medicine to the world. And he
Yeah.
basically took it upon himself to train people in street medicine. So actually seeing people in the streets, which was different than what a lot of us were doing. We were just going to shelters. And so to actually go to, like, under the bridge or in the alley or, at the encampment was a little different. And so that was in like 2006, 2007. And luckily, the medical director of the Venice Family Clinic was with me and another physician. And like all at the same time, we were like, yeah, we need to do this. Let's do this. So the other physician and I took it on, and she left to go to Seattle, and I stayed on and continued to create street medicine. That was the first street medicine team in Los Angeles.
Wow.
We joined an outreach team, and it just felt very natural and very easy. The easy part was meeting people and developing a relationship with them. And, definitely you can like take their blood pressure, check their blood sugar, try and treat them from the streets. I mean, we were really trying to woo them to the clinic, to resources. But that's when I
Sure.
just started seeing all the severely mentally ill people, because they don't go to the shelters, they don't go to the clinics, but they're out in the streets. And so that's when I was like, whoa, wait a minute. What is this whole other population that we're not taking care of? And why is it okay for, like, I was looking at some pictures the other way, and I remember this woman back when I was doing outreach in Santa Monica, actually. This woman was dressed in a garbage bag. Like, why is that okay? Why is that okay? and I
Yeah.
was and I was attending to this guy who had this huge abscess on his face, and she's like, he needs help. It's like,
The lady in the garbage bag said the guy who has the abscess,
and
yeah, and he probably looked at
I,
her and said, she needs help,
no, he
right?
was mentally ill as well. And so we started realizing, like, like it really takes a lot to care for that population. Like I didn't understand, like, I literally started talking to the hospital personnel, like, the medical directors of the emergency rooms. I'm like, one of we were collaborating with the cops back in Santa Monica, the SMART team, and one of the cops sent me a picture of this gentleman that he had been working with, saying that he took him to one of the hospitals, I won't say which, and he refused to get care and he died 4 days later. I'm like, "Wait, what happened?" And he was mentally ill. He was also an alcohol user. And he showed me he had this huge wound down to his bone, to the hip, and they wouldn't accept him. Well, no, he refused to get care. And so I literally met with the ER doctor. I'm like, why wouldn't you why wouldn't you admit him against his will? And
Yeah.
I really got down to it. And it's not to say that they did anything wrong, but when it really comes down to it, it's like, okay, that would mean I would have to put him on a hold. That means we would have to have someone sit with him until he got transferred to another hospital, because this was not a hospital that has privileges to put people on hold. Neither of the two Santa Monica hospitals actually do. So they would have had to wait until his transfer came. But I'm like, but he was medically ill. Like, you could have held him against his will and said he lacked capacity. And it was just too hard. Basically, it comes
Yeah.
down to. And
I mean, there,
there's not enough resources for somebody, whether they're medically ill and they have severe mental illness, or they just have severe mental illness and they're what's called gravely disabled. There's just not enough resources to take care of them, because there's not, and this is just California, every state is different. There is not enough, what's the word? The culture is at a point where the the importance of your civil liberties is more important than you dying, basically, in my opinion, anyway. And so
no,
that's
I think this is the challenge of anybody working with the homeless, is that people who are homeless, is that you really do, you kind of, where do you draw the line? And I see it every, I mean, I saw, as I was walking to my office today, there was a man literally laying in the middle of the sidewalk right in front of St. John's Hospital.
yeah,
And I stopped. I usually try to stop when I see people laying on the ground and say, "Are you alive?"
right,
And he got up, he sat up, and he said, "I'm alive."
yeah,
And I didn't understand what else he said. I just couldn't
yeah,
understand him, but it was very clear that he was not in a rational individual. And I feel a little bit impotent. I don't know
right,
where to begin, to what to do about this, but I do think that there is a point where a loving and a concerned culture
mhm,
says this isn't appropriate. It
right,
isn't appropriate for people to be, you know, out, defecating on the sidewalk, not having food, not having warmth and shelter in the evening, in the
right,
hour, the night. I don't quite understand that, and I'm not sure if the politicians have the will to doing much about it. But I know that in other cultures
yeah.
they are, demanding certain things of just people who cannot manage themselves. And I think you saw that with your own sister. Is that right? And
Yeah,
you wrote
I mean,
about it.
it was a little different because it came on later in life. And my so I had a sister, a half sister, who was 5 years older than me. And we she did live with us for 3 years, between the ages of 10 and 13 for me, which is pretty, important years for a tween to
Yeah.
have a big sister. So we were close. Um, and w- she lived like an hour and a half away, so not super close, like geographically. Unfortunately, she had lost her partner, maybe like 5 years prior to when some of this stuff started happening. She went out to the store and got in a car accident and died. So very tragic way to lose a loved one. Um, and, uh, and so, I was trying to be more in her life as a result. But I started noticing that she was repeating herself. Like every time I talked to her on the phone, it was the same thing over and over again, like the same 3 points that she would make. And when I visited her, her house was a mess, which that wasn't normal for her. And I wasn't, and she just seemed different, and I couldn't figure out what was going on. Like, are you depressed? And then she got fired from her job. She was a high school teacher. And so I went through all her paperwork and saw that she had just been showing movies, and so long story short is she had a genetic disease called frontal temporal lobe dementia. It took me a couple years to figure it out because your frontal lobe is your behavior, personality, and your temporal lobes is your memory and your speech. And so she started, started having dementia, but she also was kind of manic. And so there was like a mixture of dementia with behavioral issues. And so it was nothing I had seen before. Um, but she started going into people's homes and easily could have been picked up by the police and been incarcerated, for trespassing, right? So once I kind of got wind of how bad things were going, I went to visit her again, and she looked horrible. She had lost like 50 pounds. Her hair was all matted. Her teeth were all dirty, like she hadn't been brushing her teeth. Her place was a disaster. So I'm like, okay, I took her to the hospital immediately, and I'm like, let's go for a little trip. Let's go.
Yeah.
Let's just go for a checkup. And I remember telling the emergency room doctor, because she looked like a homeless person. She looked like a mentally ill homeless person. And I said, she used to look like me. She used to do her hair. She used to wear jewelry. She used to look nice. She used to be, have normal conversations. What's going on? And at the time, he didn't know either, except that the CAT scan showed some atrophy of, the temporal lobes and the frontal lobes. But I still didn't put it together. But I had to get caretakers to start taking care of her until to where she needed 24/7 care. And it was like and then it was a pretty quick decline. Um, and I mean, there was a lot of similarities. And the thing is what was causing her behavior was what we would call a neurological medical condition. And there is so much chasm. Like, this is something I don't know, even if something you've experienced, because you're a pediatrician, and I'm sure you do deal with some mental illness, but there is so much chasm between taking care of medical conditions and psychiatric conditions. And it's become such a chasm to where there's disparity. So, right,
Yeah.
whenever there's disparity, I get pissed, right?
You No,
So,
there's no question that if you have a psychiatric illness, it's really hard. First of all, it's hard to find pediatric psychiatrists, number one.
oh yeah, for
And number two,
sure.
it's hard to get them properly cared for because there's only so much room at UCLA, and I'm talking about people who have private insurances. Usually, it is like pulling teeth.
Yeah.
So you're absolutely right. There's a gigantic disparity, and I don't have a good answer for it. I don't know what to do.
Well,
Um,
we have to see it as a medical condition, just like frontal temporal lobe dementia is a neurological medical condition.
yeah,
Schizophrenia is a neurological medical condition, and we can't treat them differently. So I'll just give one little example. Also, I had to take care of my mother who had Alzheimer's. Like when she started around 72, I had
yeah,
to step in. And that this one time, I mean, actually my mom was pretty funny. She escaped her caretaker at the mall, and she found her way home. but in the interim, we're freaking out, right? Like, where was she? So she was in the valley in Sherman Oaks. I'm in, I don't know where I was. I was probably at Harbor at the time. I'm calling the police at Sherman Oaks saying my mom has dementia. And they're like, this is an emergency. We're on it, ma'am. I swear to God, they were on it. They were looking for her. But had I said this was my daughter who has schizophrenia and she escaped her caretaker, they would have been like, oh, sorry, we can't do anything. That's her right to leave her caretaker. And that's what
Yeah,
that's the reality that we're dealing with right now. But I do a lot of advocacy. I have a lot of ties to legislation, and so I'm trying to make changes on a large level. Not
yeah, no. My subtitle of my show is Where Kids and Culture Collide. Just with your work with the homeless clinic and the healthcare clinic down there in Los Angeles. Tell me a little bit about your take on children who are enmeshed in this situation.
I don't have a lot of interaction with little children. The people that I have interaction with are the youth. And so when I was
Like
working in
teenager, you're talking about teenagers.
teenagers or what's called TAY, transitional youth, so the 18 to 25 age, which is still, they're still kids
Yeah,
basically. um, so like in Hollywood, I would come across some teenagers for sure. I think a lot of teens, a lot of those who are experiencing homelessness, especially teens, or young adults, are in or out of the foster care system. So there's definitely something going on there. The statistics are pretty horrible. A third of foster kids will be homeless at one point in their life. So, something to think about. And there's also, a large percentage of LGBTQ teens that are experiencing homelessness, and most are using substances. That's the big coper. And most of the people I work with, especially in downtown Skid Row, are substance users. And my opinion is that they're coping with trauma. This is their way to cope with their trauma. And they've had, you know, it's not to judge their trauma. Whatever their trauma is, it's their trauma. And they didn't have the coping skills, or whatever, or my coping skills is eating. And so that's more socially acceptable than heroin.
yeah,
Not by
for
much.
sure. No, listen, there's a reason why people are out there on the streets. I have to tell you, Susan, and you'll appreciate this. When I see homeless people, I extrapolate backwards,
Yeah,
and I try to visualize them as little boys and girls that I take care of,
exactly.
because they
Exactly.
were that at one point in their life,
We're
and
innocent.
as
Yeah.
a beloved child of their mother or their father,
Right.
and something went crazy. Something went haywire in their life, which resulted in them being on the street, like the gentleman I ran into today on the street. He was a little boy one time. He was this week. Maybe he played baseball. I don't know who
Yeah.
he was or how he grew up, but there he was laying on the street, literally totally disheveled. And in my mind, he seemed to be out of his mind when I spoke to him. Um, we have a lot of work to do, and I'm not sure all the details. We don't have time to go into the details of your advocacy, but I wish you well on that.
Mm,
Um,
thank you.
I do wanna. I'm looking at our time here. I know, and I promise you to not take too much of your precious time. But before we go, I'm just the last thing you've been doing is you've been doing this thing in Haiti, and I'm not sure you're still doing that, but I know that you have an organization called HEAL,
Yes.
HEAL. Can you
Yes.
briefly tell us a little bit about your work in Haiti?
Yeah. Actually, you said you used to do some work in Jamaica, and I started taking medical students with another attending physician, UCLA students, to Jamaica. I did that for 3 years, and then I ran the last year, and I'm like, okay, I can do this. But I had a medical student whose husband was Haitian, and she was like, I want to go to Haiti. And I was thinking, I'm like, I think Haiti's a little bit more needy. And I wanted to take third years, not fourth year medical students, because I wanted to give them that experience before they decided what they wanted to be when they grew up. And so started taking started with 4 medical students in 2009, right before the earthquake. We came home January 2nd. The earthquake was January 12th. So I missed the earthquake by 10
Thank
days.
God you weren't there. That would have been terrifying.
We
Yeah.
were we were
Wow.
at the places. We were at the grocery store or the hotel, the famous hotel that collapsed. We saw the presidential palace. We saw all that. All that was destroyed in the earthquake. So I felt a calling to go back. I put it out there that I want to go back as a family physician in emergency situation. You feel kind of like, what do I know, right? I don't
Yeah.
know how to operate. I don't know orthopedics. I don't know anesthesia. I'm not an emergency medicine doctor. What can I do? So anyway, a friend of a friend of a friend hooked me up with an organization that was looking for primary care doctors. So I'm like, all right, I'll go. It turns out that everyone needed primary care because they didn't have primary care to begin with. So and so I the woman who is the now director of the organization that I just happened to be united with, and I think it was divine. We have the same birth dates actually. And she's, we call each other sisters, and so because of her, I've been able to go back every year bringing students. At first, we would bring them to her hospital in Port-au-Prince, and then she introduced us to this area, a rural area that's about 4-hour drive from Port-au-Prince, so really, really out there. And so now, or not now, but we, for like 5 years in a row, we were just going to this rural area where we'd stay a whole week and do primary and urgent care there, pap smears. Yeah, so like really trying to bring primary care, bringing a year's worth of medication for them, because but what we did do also is we found local doctors. And so
Yeah.
now paired up with a local doctor, and Gladys is the woman's name, my sister. She is the director of a college there, and they have a nursing school. So the nursing school and the doctor continue to care for those patients year round. I support the doctor, or Heal does. Heal supports the doctor. So the last time we were there was 2019. We didn't go in 2020 because of COVID. And then all hell broke loose in Haiti, and
Yeah.
been
So there have been,
completely
as
unsafe.
you know very well, that there have been missionaries who recently, a couple of them killed down there, and kidnappings and things like that. So I'm sure that the level of violence has increased, and also just lawlessness in general. So
Yeah.
I get it. I know why you're kind of laying low right now, and I'm sure you want to go back. It's been
We
5 years.
brought we brought almost 70 medical students over the last 10 years.
Yeah.
I got to experience that kind of care. And so, I hope that they took that away with them for their future careers. And
No,
that was the
I'm sure
purpose
that
of
they did,
bringing third year medical
Doctor.
students. Yeah.
Yeah, that's a time when you really are very impressionable, and it is
Yeah.
a great time to take people over there.
Yeah.
Well, listen, our time has come that I need to sign off. You need to sign off.
Yep.
I want to thank you from my heart. You've been an amazing guest,
Aw.
and I wish you the very best. I really have to say I'm inspired by your love for people and your ability to see beyond their obvious, to look at them as people and not just another person, another homeless person who's a druggie or whatever you want to call them.
Right, right,
So
right.
God bless you for that. You're doing God's work. I mean that.
Thank you.
Um, you are welcome. And friends, those of you who are listening, I want to say thank you for tuning in today to the Hamilton Review. We have had a great conversation with Dr. Susan Partovi. Her name is spelled Partovi. She has written a book called Renegade MD. It's available on Amazon. It is a great read. I encourage you all to find it and read it, and you'll be inspired as I have been.
Aw,
And so thank you, Susan.
thank you. So great to meet you.
Good to meet you too. And
Um,
friends, thank you for tuning in. Until next time, be well. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.